Hello, I'm Alex Abbott. Thanks for joining in. I'm going to be chatting about shin pain today, briefly just covering the colloquial diagnosis of shin splints and what that means, and differentiating some important factors for bone stress injury. Many times when patients have shin pain, they suggest a diagnosis as a presenting complaint, shin splints. Unfortunately, shin splints, or medial tibial stress syndrome, abbreviated MTSS, it's not as concretely defined as other types of injuries can be. Most commonly, shin pain is an umbrella term which can encompass MTSS, and MTSS is defined as an overuse injury that's marked by periosteal edema. The periosteum is the outermost layer of bone. The definition of MTSS has evolved over time to also include the suggestion that MTSS is like a pre-bone stress injury, or BSI, without features of the lowest grade bone stress injury yet. Studies in the future, with the aim of objectively studying MTSS progression to BSI, would be helpful to confirm that characterization. Despite our best efforts to nail down a definition that includes the specific structure involved or the mechanism for injury development, the term shin splints is used colloquially to be synonymous with shin pain in general, soft tissue pain, basically anything other than a stress fracture in the tibia or fibula, and pre-bone stress injury. Periostitis, which is a more objective and a definition that we should be probably pushing closer to. Periostitis is not a term that patients are usually familiar with. So when patients are researching their shin pain online, they often self-diagnose with looser definitions and then come from a starting point of poor understanding. With that poor understanding, further, the term shin splints, interchangeably used with exercise related shin pain, starts to blur your differential diagnosis for shin pain into one etiology. So, someone might be looking up my shin pain and they get shin splints, they get pigeonholed down this rabbit hole of how to treat and manage shin splints. But this can be problematic because the separate items on the differential for shin pain require slightly different treatment emphases. Dissecting the anatomy of the shin on the right, our pain culprits might be the muscles that control ankle motion, especially dorsiflexion for the muscles on the front of the shin, or the muscles controlling foot motion, especially toe extension. We could have an issue with bone stress resulting in periostitis. That's our true MTSS definition. Or we could start progressing to a bone stress injury that's weakening the cortex of the bone, and we're starting to see marrow edema itself. Finally, a rarer etiology of exertional compartment syndrome can present with shin pain, where this is where blood flow through defined compartments in the leg is compromised by increased pressure during exercise. So the differential for the umbrella term of shin pain is quite broad, and shin splints, or MTSS, is just one item on that list. Again, separating these etiologies is important because patients often start with shin pain equals shin splints, and they don't respect or fear the potential initial symptoms of bone stress injury. Bone stress injury essentially comes about when the adaptations of bone that is loaded can't outpace the breakdown of bone. This can occur related to inadequate nutrition, excessive loading when exercising, or an inadequate recovery period between your training sessions that doesn't allow those adaptations to occur. Half of bone stress injuries occur in the tibia. This is the most common location for this injury. They're also common in runners, gymnasts, basketball players, soccer players. So think high impact, repetitive impact, especially if someone is ramping up their volume and their increased volume of activity looks like going from 0 to 100 too quickly. The most common athlete types with bone stress injuries also represent sports that emphasize leanness, so things like running, gymnastics, and dance. There's a well described association with low energy availability, menstrual irregularity, or other hormone imbalance for male athletes, and then low bone mineral density that can make athletes who emphasize leanness at a risk for bone stress injury development. This used to be called the female athlete triad, but it's referred to as relative energy deficiency in sport, or REDS, because it can affect men as well. In pediatric patients, we most commonly see bone stress injury in our adolescent populations. So, if you have an adolescent who's focused on leanness in some way, maybe engaged in the sports that we discussed, maybe increasing their volume recently, complaining of pain near the most common site for bone stress injury in the tibia, you should definitely profile this patient. When thinking about bone stress injury rule out, starting with an x-ray is helpful as a screening tool, but an MRI allows you to confirm or rule out your diagnosis more definitively and then grade a bone stress injury if it's present. You can also use that grade to stratify them for risk. So if they're high grade, then you're thinking about treating them more conservatively. And that also helps to give you a sense of prognostication so that you can guide them for how long it's going to take for them to return to sport. Grading the MRI, using MRI to grade the bone stress injury also helps to guide specific nuances of rehab and return to sport, such as initial rest time needed and then how conservative you are with returning to impact. In addition to characterizing the bone stress injury in the shin as high or low risk based on the specific location, the return to sport progression using the grade based on your MRI findings is really helpful. So, full discussion about bone stress injuries head to toe is out of scope for this brief shin pain talk, but your high risk site in the shin is the anterior tibia. Lower risk sites are your posterior medial tibia and the fibula. These are more likely to heal with just rehabilitation when done properly and less likely to require surgical fixation. Finally, we're moving away from calling every bone stress injury a stress fracture. This term is starting to be more defined for bone stress injuries with linear signal change in the cortex that's indicating your fracture line, which would be a grade 4 BSI. BSI treatment starts with rest to essentially put the fire out of the initial injury and allow the early healing to start. Once pain is resolved, we can assume clinical healing and start the challenge of loading and starting to challenge the bone to strengthen. And we use a gradual loading progression. During the initial rest phase of 3 to 6 weeks, taking more time to rest, so more on the order of 6 weeks or more, might be indicated for patients who are still symptomatic after 3 weeks of rest, those who have higher grade bone stress injuries at the time of their diagnosis, and or those who have bone stress injuries in high risk locations. In our case for the shin, that would be the anterior tibia. If a patient has a high-risk site and you want to optimize their chances of healing, using a cam boot and or crutches to fully shut down load on the bone can be beneficial. If the patient has a low-risk site, they've not got pain with weight bearing, and you want to optimize your rapport with the patient and encourage kind of sticking with the recovery plan for the long haul, you might consider deferring the boot and crutches if you don't think the patient will need it. The boot can also serve as immobilization for a patient who doesn't adhere to rest without something physically slowing them down. These photos show how even if you can't grade the MRI with it or grade the BSI with the X-rays, you can catch them with for screening in your clinic. So that picture on the left shows bone stress injury that we were clued into just by their X-ray alone, and then they progressed to getting an MRI to grade the severity. The radiograph on the right shows the dreaded black line of the high-risk anterior tibial bone stress injury and the reason why it's dreaded right behind it. This patient required fixation. When patients are diagnosed with bone stress injury, I'm transparent about our planned return to sport protocol to help set expectations early. Unless I'm worried that previewing the next phases will tempt them to start taking shortcuts, I will show them what phases are in anticipation and explain that the minimum time to complete the process is around 4 months. I also explain that pushing through pain and trying to expedite the process can paradoxically make return to sport take months longer. Going through these phases one time properly and having stronger bones at the end is preferable to the endless build up and breakdown cycles of completing these phases over and over again too quickly. I think about the Sisyphus allegory as one that comes to mind when I talk to patients about this. Sisyphus is a man in Greek mythology who was doomed to push a boulder up a hill only for it to roll to the bottom endlessly. And this is the fate for the athletes who don't tell you about pain and they continue their return to sport progression inappropriately. The first phase in the protocol is the unloading phase, which we described previously. The next phase involves low impact cross training and strength training with the end goals of strengthening the muscles that support loading through the shin and having the bone stress injury site being healed and remodeled enough that pain is not present with longer distance walking. Phase 3 starts gradually increasing load through the bone with jogging and plyometrics. And then phase 4 starts a return to running or return to goal activities progression. So, similarly to a patient presenting with any chief complaint, a headache, chest pain, fever, the safest practice is usually to rule out a worst case scenario. So, in those same kind of cases, headache with brain bleed, chest pain, and worried about cardiac, and then fevers, you want to make sure that you're not concerned about serious infections. For shin pain, you want to rule out bone stress injury first, especially if your patient shows you the risk factors that we talked about. Once we rule it out, we can more confidently diagnose the more benign MTSS or shin pain, and then proceed with treatments that allow athletes more freedom and less strict restrictions. We're thinking about pain as our guide rather than those strict timelines. It becomes a lot nicer. Some of the clues that support shin splints or MTSS as your diagnosis before or after your bone stress injury rule out start in the history. So if they're telling you pain is exacerbated during exercise, but it's not unique to the other items on your differential, that is really helpful. If there is nighttime pain, there are anecdotal reports that bone stress injury is more commonly associated with nighttime pain, but this is not studied well objectively and needs more evidence to make it as a rule. On exam, your diffuse pain is going to be more reassuring for that benign diagnosis of MTSS, and focal pain is more concerning for a specific bone stress injury site instead of the diffuse periostitis. There is suggestion that 5 centimeters or more could be considered as a threshold for what is diffuse versus focal, but in my research, this number seems arbitrary and doesn't seem associated with MTSS versus bone stress injury likelihood. I couldn't find any studies to explain this number. MTSS pain shouldn't be reproducible with non-weight bearing foot or ankle motions. That'd be more concerning for muscular strain, or if you're doing repetitive motions like ankle pumps and able to recur that pain or reproduce that pain, then you start thinking about exertional compartment syndrome. X-rays are good for screening, but like I said, an MRI for ruling out bone stress injury is definitely reassuring. For just a patient with MTSS, an MRI will just show diffuse periosteal signaling rather than the focality of a bone stress injury, or for a muscular strain, you'd see signal in the muscle itself. I have an excellent case. This helps to illustrate very well MTSS versus BSI because this patient had both over time. So this 15-year-old ballet dancer, she initially presented with shin pain, which is left worse than right. She's diagnosed with a fibular bone stress injury based on her X-ray and MRI, and then she starts a period of rest from impact, followed by her return to sport progression for a bone stress injury. You can see her fibular X-ray with very subtle changes over the tibial border of the fibula, so the tibia side of the fibula in the shaft of the diaphysis. And then the significantly increased signal on the MRI when you look at the fibula, the skinny fibula, relative to the tibia, which isn't lighting up very much. So you can use those two bones to compare how much signal is there. The initial presentation through the diagnosis is on the same slide here. So this is obviously not the interesting part of the case. This patient's symptoms resolve after the rest period, but then after starting plyos, which is bone stress injury phase 3, she returns for concern about recurrent shin pain. The MRI is reassuring against recurrence, and the presence of periosteal and muscular edema instead suggests soft tissue stress, or MTSS, or our colloquial diagnosis of shin splints. Interestingly, she shows some muscular edema posterior medial to the tibia, and then periosteal edema along the medial border of the tibia. Essentially, on her initial presentation, she showed a clear fibular bone stress injury without any other concurrent diagnoses. And then on her follow-up, she demonstrated nearly every other item that's on the differential for shin pain. I was particularly proud of this patient for following up with the recurrent shin pain rather than pushing through like the Sisyphus allegory, and the evidence that her bones are not asking for another shutdown period. They're not showing me problems with the loading, allow her to now continue progressing through the protocol with confidence and just one time only. To contrast with the treatments for bone stress injury in that protocol, compartment syndrome, that can require surgical intervention such as fasciotomy. Muscular strains, they'll often benefit from PT for specific muscle groups. And then MTSS is often less formally treated than bone stress injury with rest and then just gradual return to play over 2 to 6 weeks. I always hope that when I tell patients all you need is rest, that's a good news item for patients, but they usually look at me like this athlete on the right. However, MTSS patients, when you've ruled out the bone stress injury, they have more license, more freedom to return as tolerated. They can use pain as their guide instead of being conservatively cautioned about slow return and following these evidence-based restriction timeframes to zoom out and try and avoid surgery. Again, I'll emphasize that it can be crucial to see past the patient's self-diagnosis of shin splints, even if the patient's coming in and their complaint on your schedule is, I have shin splints. Think about, what is shin splints, MTSS, is that the correct diagnosis, and what is my broader differential? This slide is our more short version of MTSS. We'll have another talk a little bit more in depth about rehab protocols, but thank you for your time and thanks for your attention. These are some really excellent resources used to source the talk. And this is our information for Stanford Children's and how to get in touch with me or see me in clinic. Thank you.